Okay, everybody. Well, good morning. Um, I'm going to go ahead and get this show started for the exciting day we have planned for today, and it's my distinct pleasure and honor to say some opening comments about our president. So I'm Rob Coleman, and as the immediate past president of this wonderful society, it's my honor to introduce Dr. Fujiwara to you. So I first met Dr. Fujiwara Keiichi more than 20 years ago. It was in 2020. It was my first trip to Japan, and it was at a conference kind of like this. We were kind of supporting two different taxanes at the time. I was on the presenting data from the U.S. on paclitaxel. He was presenting data from Japan on docetaxel. So it tells you how long ago that was. But we quickly found a kindred spirit and really started to get to know each other's passions and start to work together on a number of different projects. But let's go back a little bit, and you can see here a photo of young Keiichi on the right there with his twin brothers and sister on the left hand. And then later, you can see him here as a young clinician researcher, and you can already tell the passion and vision in his eyes. This is during a GOG at that time, NRG audit. You can see Dr. Fred Stamen there, trying to listen to what he's got to say about the data quality. So Keiichi received his medical degree from and PhD from Okayama University School of Medicine before becoming certified in gynecologic oncology and becoming involved in clinical investigation. This certification process was new. So Keiichi was part of this initial class of physicians to go through formal process of being certified in gynecologic oncology. And it was very great to share that journey with you as well. And he's been the PI for GOG Japan since 2007. He's been involved in various committees and leadership roles, and the GOG and the Japanese Gynecologic Oncology Group, NRG, the National Cancer Institute, and the Gynecologic Cancer Intergroup, of course. And here are a few more images from his past in the operating room. Let's see, where's your operating room picture here? Did I miss it? There we go. Okay. In the operating room with his team and at IGCS in Bangkok. And he has several years of experience, including council member service, obviously, for the Japanese Society of Clinical Oncology and the Japanese Society of Gynecologic Oncology. And seeking out international collaboration, he served on committees with the SGO, FIGO, and of course the board of the International Gynecologic Cancer Society. And you're sure to find him at scientific conferences all over the world, surrounded by friends and colleagues. And here he is at the IGCS meeting in Kyoto and in New York. And I know from experience, when you begin a 6-year presidential track with the IGCS, you're in for a transformative experience, especially with the IGCS experience such growth and vibrancy within its membership and programs. In fact, Keiichi's, here's you can see Keiichi making the rounds with IGCS CEO Mary Aiken. And here he is with longtime friend Dicey Scroggins. I know Keiichi has said much about Dicey and how much she has taught him about patient advocacy and the meaningful engagement of patients at work that we do every day. And this advocacy experience in Japan actually was also quite new, something we experienced together early on in the early 2000s with patient advocacy groups really springing up and starting to receive some traction in his country. And if you know Keiichi, you will learn that he's a man of diverse interests and many talents. He's a lover of the arts, and as you heard yesterday, a gifted musician. You are a gifted museum, Keiichi. In fact, he plays this bassoon. Here we go. Sorry, he plays bassoon, and it's one of the most complicated and difficult instruments that you can hope to learn. I just learned yesterday that the air, the reason you get so out of breath is the air has to travel through those two tubes to actually come out the end. So it's quite an experience to play, and he does it so expertly. But if you're really lucky, you will be able to see what his real talent is out during karaoke. And yes, I can tell you, he can sing. So let me tell you a little bit of one of my very first experiences with Keiichi going out to karaoke back in the early 2000s. I had never really been to a karaoke any place karaoke facility. So Keiichi was kind enough to welcome me there. I was very nervous because I thought they're going to put me in front of this room and I have to sing by myself, and I'm a terrible singer. And so he's like, "Listen, I'll help you out." And he took the mic, and from the back, well, I heard this. So if you don't know this song, it's actually by Bruce Springsteen, and it's called "Born in the USA." So thank you for that, and he did a great job. But for the rest of us, we're better off to stay sticking with our day jobs. And although we have tried to try to top that, and with the appropriate amount of material, we think we sound very good as well. But back to Keiichi, again, there's the more you get to know him, the more you learn that he sees beauty in all the things around him. He's a photographer. You'll see him at meetings almost always with a camera, and he captures with a keen eye the spirit and beauty of the ordinary. And I think this contributes to his innovative thinking on research and critical evaluation. His integrity, humility, and approach to life has certainly influenced his work with the IGCS. And this makes Keiichi the perfect president to champion equity in access to palliative and supportive care. Under his decisive leadership, IGCS has made a bold declaration, as you can see here. And he will lead our society members as we work to close the gaps between curative and compassionate care. So without further ado, I'd like to welcome you, our president, Professor Keiichi Fujiwara.
Thank you, Rob. Pleasure. Well, thank you, Rob, for your kind introduction. And I just memorized it. I brought my students to the karaoke bar, year of the 2000, and let him sing a song for the first time in his life. It was fun. And thank you for your friendship, continuous friendship. Okay. So thank you for gathering here today. And I'm Keiichi Fujiwara, the president of the IGCS. And as you can see, the title of the presidential plenary is relieving serious health-related suffering for women with gynecologic cancers. So, like many IGCS members in this hall, in my career as a gynecologic oncologist, started my training wanting to be a best surgeon, best physicians, to deliver the most effective treatment options to cure my patients and get rid of their disease. Okay? So the consequence is when my patient survived, I thought it was a great success. But if I lost my patients, I felt like I failed. So you all understand how it feels to lose a patient. So I felt that needs to be the best surgeon to discover the best therapeutic treatment to provide a cure. On the other hand, you all know how it feels when you see your patients, my patients, suffering not only from their disease, but also from the side effects of your treatment or from complications. So our patients are going through a very difficult time physically, emotionally, and psychologically. So we cannot and we should not ignore their suffering. So when you first learned that the presidential plenary was about palliative care, I wonder how many of you thought that, oh, that meant end of life care? How many of you thought that it was not very important for your practice, that it wouldn't help you be a better doctor for your patients? It's okay. I used to think so too. So I thought palliative care was only for end of life care, hospice care, a last resort. So when I thought of palliative care, I thought that meant that I failed, and I felt guilty for having to talk about palliative care to my patients. But after more than 30 years of my experience, I know how important it is to understand what these terms really mean and the intention behind them. So, because the words matter, especially when we need to communicate complications, complicated ideas and problems that need solutions. Now I know that palliative care is not just end of life care. Palliation means supportive care that relieves patients' suffering. It isn't as simple as that to relieve suffering. As the president of the IGCS, I have used of this stage to speak to the largest, most diverse gathering of gynecologic cancer specialists and the caregivers in the entire world. When we were planning this session, my friend Michael Pearl said we need to learn to love palliative care. Yeah, that is very important, I thought. So if you are like me, let's try to see things differently. Or maybe you are already aware, but you don't know how to incorporate the palliative care into your practice. Or maybe you have challenges accessing the required service and medications. That's why I think that topic is so important to talk about with all of you gathered here in the same room. We all come from different cultures, different settings, and with different resources and different medical training. But you made a decision to journey to the IGCS meeting. You came with an open mind to share ideas with your international peers. Together, we can shape our own culture. That is the IGCS culture. So when I tell you that IGCS has declared our commitment to palliative care and supportive care a couple of weeks ago, I hope you understand that we are calling on all of you to join us in the commitment. IGCS is only as powerful as the individual within. Those of you in this very room, whether you are a member or not, you are part of a community. Yes, we need you, and your colleagues need you, and your patient needs you. It should not be acceptable to sacrifice quality of life when we decide to the best treatment. I understand that there are big challenge, very big challenges and the barriers we must discuss and work to overcome, especially those in areas with limited resources. Lack of access to essential medicine like opioid is a major problem. When I visited Vietnam in February of this year, I learned that many young doctors were having difficulties controlling their patients' pain. And it was a moment that I awakened my sense of duty to do something about it. I thought about how IGCS and our members have an important role to play in closing this gap. One gap is the translation of the term palliative care, as I said, and understand that it does not simply mean end of life care, okay? The other gap will be much bigger. So, but with so many of us together, pledging our community to affect changes that we can bring to fill in the gaps. So I invited Dr. Stephen Connor to give us the keynote speech today. Dr. Connor is the executive director of the Worldwide Hospice Palliative Care Alliance, an alliance of over 450 hospice and palliative care organizations in over 100 countries. He has worked continuously in the hospice and palliative care movement since 1975, and he serves on the multiple boards and technical working groups for the WHO. He has published over 175 peer-reviewed journal articles and book chapters, including 6 books on palliative care. Dr. Connor, welcome.
Great. Thank you very much, Kichi. Well, good morning, everybody. It's great to see all of you here, and thank you for coming to this session. And thank you, Dr. Kichi, for your bravery in raising palliative care as an issue and supportive care. When we do national cancer control plans, typically they have 4 components. There's prevention, early detection, treatment, and palliative care. And without all 4 of those, you don't really have a coordinated or comprehensive national cancer control plan. So the WHPCA is, its purpose is to advocate for palliative care in the global policy making arena, including the WHO and the United Nations, but also on the ground to help develop palliative care from the roots up, not just the top down. Next slide. Oh, I can do that. Sorry. Yeah, just for the record, I have no conflicts to disclose other than my interest in better care for patients with serious illnesses. So we've already seen the definition of WHO for palliative care, which is in a publication that I'll show you in a moment. But it actually is WHO's definition going back to the 90s to identify that palliative care is about putting the patient and their family at the very center of everything we do in the care we provide to our patients, and making sure that we are dealing not just with their medical or physical needs, but their psychological, social, and spiritual needs, the whole person and the whole family. Without we don't just care for patients, we care for patients and their families always. It's it's a fundamental principle of palliative care that families are cared for. So we published the Global Atlas of Palliative Care, and that little WHO logo in the corner is something that takes some years to get. But our purpose in doing this was to create an advocacy document so that we could understand, paint a picture of palliative care globally and be able to advocate for it. We look at how many people need palliative care. We look at how many people are getting palliative care, and then we can measure the gap, and that gap is something that we need to close. We also look at the various barriers to achieving that, the resources, the development of palliative care globally. This is the second edition. We're working on the third now. And in determining how many people need palliative care, we got together in the Lancet Commission on Palliative Care and Pain Relief and actually created a kind of a paradigm shift for palliative care and what it means globally. As Keiichi said, most people think of end-of-life care when they think of hospice or palliative care. Hospice is, by and large, about end-of-life care, but palliative care is a much bigger discipline. And we always try to help people understand that we're talking about people with serious illnesses and people with serious health-related suffering. That's where that language came from. We don't talk about terminal ill patients, life-limiting, life-threatening, because people don't understand what those terms mean anyway. But I think everyone pretty much understands if you have a serious illness, you need to get extra support. You need an extra layer of support around the patient and the family. So we also developed a methodology that measured how much serious health-related suffering people will experience as their illness progresses. And that's determining the need, not based on prognosis, not based on what treatments you're getting or not getting, but simply what is the burden of suffering that you're having to experience and carry with you. As a result of this, this was before the pandemic actually even hit. The estimates were around 60 million patients and families needing palliative care. 57 million in 2019, but then we saw a whole lot of people with COVID who needed palliative care, and we're seeing a curve that's going upwards as the population of the planet ages, so that need is going to continue to grow. Most of those people are living in low and middle income countries. About half are what we call decedents, or those are the people who need palliative care in the year that they're going to die from their condition. But there's more than half who need palliative care months, years, sometimes many years before they actually reach the end of their life. So we acknowledge that palliative care is more for people who aren't at the end of life or dying. And again, as I said, low and middle income country disparity is enormous. We have about 50% of the need for palliative care being met in high income countries. And only 4% of that need is being met in low and middle income countries, where 82.5% of the need exists. It's sort of an 80-20 problem. We've got most of the services in high income countries, but most of the need in low and middle income countries. And I think it's really a task for all of us to figure out how do we do that. And one of the ways of doing that, and this is a word Keiichi likes, is that we've got to integrate palliative care into our existing practice patterns. And we need specialist palliative care, but we think about 2/3 of patients actually could be cared for by their primary care teams or specialist care teams without specialist palliative care necessarily being needed if they were trained in even the basics of palliative care, which no one should graduate from a medical school or nursing college or mental health training in university without some at least basic training in palliative care. Most people have non-communicable disease. We've seen improvements in reductions in child mortality. We've seen reduction in deaths from from AIDS, though we're now starting to see an increase in what we're calling advanced HIV disease, which is essentially people who are HIV positive who are more susceptible to non-communicable diseases. We know about, of course, HIV-related cancers, KS and such, but we're seeing a lot of vulnerability to inflammation and a lot of early mortality for people with HIV and TB as well. Most people are older. But we also need palliative care for children. And we've underestimated that need in the work that we've been doing. We're making corrections to that. We're seeing, because of the lack of access to opiates for pain for palliative care, we're seeing the majority of people, the 25 or 26 million that need palliative care at the end of life, almost all of those, 18 million at least, don't have access to opioids at all. Either the country doesn't have them, or their regulatory structures are so onerous that they can't access medicine. And then we also, palliative care also is about supporting families both during and after a patient dies. And so we see hundreds of millions of people grieving after a death. For gynecologic cancer, the burden is quite huge. The top three, cervical, uterine, and ovarian cancer, are literally, we're talking about a total annually of almost 650,000 women dying of gynecologic cancers each year. And so we can't ignore that as part of the practice of gynecological cancer treatment. It's a huge burden, and the burden is not just dying; it's suffering before death, which we looked at in several articles in ASCO's Journal of Clinical Oncology, Global Oncology. I don't know if you're aware of this, but cervical cancer actually has the highest percentage of moderate to severe pain of any cancer. So you know from your practice that patients have a great deal of cancer, but this is evidence that 84% of women will experience moderate to severe pain. Vaginal discharge, 2/3, and bleeding, 61%. Loss of, this is not just about physical suffering, but psychological and spiritual suffering, loss of faith, anxiety, depression, decreased sexual dysfunction is very high, 87 and 83%. So this is a huge burden of serious health-related suffering that we're talking about in this population. And we have a package of services that was developed, a minimum package for every woman that is receiving or has cervical cancer. This is a focus on cervical cancer because of the numbers, the high mortality rate, and the high burden of suffering. Now, just to give you an example, this is a woman who I saw in Albania, Blerta, who was had just been brought in to the palliative care unit with stage 4A cervical cancer. She had been there about a week, and when I went to see her, I asked her how much pain she was having, and she said that she was in a lot of pain. I asked her treating team members if they had given her any pain medicine, and they said, no, she just likes to complain. She's not really in pain. So one of the things that we always teach initially is to be sure to believe patients when they say they're in pain, because they are. It's a phenomenologic experience. And so we did get her, we were able to get her on oral morphine, and she was able to, she's looking a lot more comfortable in bed in this picture. Anyway, common problem. So I don't know how many of you are familiar with the Pink Book. Raise your hand if you've seen the Pink Book. Not too many of you. This is still the most recent comprehensive cervical cancer control guide to practice in the second edition. We worked on this for WHO and developed the chapter on palliative care that's still there in the essential practice guide. You can't read this probably from there, but these are some key points from the chapter on palliative care, and that it's an essential component of cervical cancer control. And that it should be provided by an interdisciplinary team, and symptom management, holistic, if you will, care for the patient. We sort of think that palliative care and supportive care are models for how our healthcare system should treat patients when they have serious illness, non-communicable disease in particular, but also some of the communicable diseases. We have sections on the role of family in palliative care, comprehensive, holistic approach, the role of healthcare providers, managing common symptoms in advanced cervical cancer, keeping the patient and their circle of those caring for her informed. So as we said, evaluation and treatment of pain is a high priority for cervical cancer. Managing fistula, vaginal fistula, bleeding at home, and conversations with patients returning home from palliative care. There's one of the things that is a myth about palliative care is that it's a building somewhere that they send you to. In almost all countries, palliative care is really delivered in the place people call home. So for your patients, you should know that palliative care is going to be able to bring them care and their family care in the place that they live. And building palliative care in each country requires certain elements that are key. We used to have a sort of triangular model. This is the new model. It's a house model for palliative care because we forgot to build the basement when we were building the house before. And so we know that it's not just, medical professionals who are involved in the care. 95% of the care when people are at home is done by family members. They need to be trained. They need to be supported. They need to be taught how to deliver care. And by family, we mean the person's most immediate attachment network, really. It's those that are around the patient, their friends, family, those who are close and attached emotionally. We also need health policies and research. Without policy at the government level, you can't deliver palliative care at the local level. But the real pillars of this are education and training and access to essential medicines. Well, this is the new model, and so we'll go through this a little bit. What we usually do when we start working in a country is to assess the need for palliative care in that country, and not just the numbers, but what are the unique characteristics that country has in terms of its healthcare system, its culture, its population, and attitudes. We need at least a law that says this is what palliative care is and it should be part of healthcare. We need standards for how you operate a program, how you operate a palliative care service in a country. What are the standards for training, staffing, medical records, all that sort of stuff. We need palliative care to be recognized as a specialization within healthcare. We have about at least 35 countries that have recognized palliative care as a specialization. Most countries, it's a subspecialization, but we have a good number that have it as a full specialization, and 2 countries where it's both. There ultimately needs to be a funded national strategy for delivering palliative care. And that should be in sync with all the other health policies within the country. But getting the funding, particularly in low and middle income countries, is quite challenging. Though really, when you think about it, it's not just money that we're talking about. It's changing attitudes. It's changing training so that people will change the way they practice. It doesn't necessarily cost more money. It doesn't cost you more money to do palliative care in your own practices. It will require training, additional training and support, and sometimes some additional staffing. But it really helps the healthcare system because what we do is essentially help reduce unnecessary trips to the emergency room and the hospital, and providing care at home isn't free, but it prevents so many expensive costs in every healthcare system, hospitalization in particular, that it really actually pays for itself, according to the research. Anyway, the funding is needed. For research, we do have country-level indicators that every country can use. We are measuring the impact that palliative care has on the healthcare system. Does it reduce poverty? Is it cost-effective? We have a lot of evidence in high-income countries that this is the case. We are beginning to build evidence in low and in upper middle and lower middle income countries that in the same sort of pattern happens with patients. It's really about prevention and promotion of health. It's not just about uh, treating symptoms or treating the disease. It's really helping build strength for that person. And also, there's opportunities for growth when your symptoms are well managed. When you're well managed, there are existential experiences people have that help them find meaning in their suffering. We also need random control trials. We have about in the 80s, we had to stop randomly assigning people to palliative care and non-palliative care because the body of evidence for the benefits of palliative care had grown to such an extent that it wasn't thought to be um, it would be unethical to do so. And we need qualitative research. We need to ask patients and families what they think about the care they have, and we need to look at the quality of care. As I said, every professional in health care should get at least basic training in palliative care based on clinical guidelines. And really, we need palliative care at all levels of the healthcare system. And in the community, we need to make the public available. At the same time that we're training professionals, we have to sensitize the public. If you have training for professionals and not the families, when the physicians and medical staff recommend palliative care to be considered, the patients go no. Uh, and then if the patients ask the physicians for it and they are not trained in it, then they say no. So it needs to be parallel. There are a whole long list of official essential medicines in the WHO model list of essential medicines for palliative care. Um, of course, for pain, we still are finding that oral morphine is the best treatment. Oral, sometimes long acting, short acting, as well as injectable. But we need a host of other medicines to help manage the symptoms of the illness. And these are mainly drugs that are controlled medicines that need to be provided, and are oftentimes hard to get because of too many regulations and control. So we have home-based care as really the major way of delivering palliative care. We do need inpatient care. We do need consultative services, but we really need to integrate palliative care into primary care and in specialty practices. Global consumption of morphine is only 5 milligrams per capita. Um, this is really inadequate, and it reflects in this map, the lighter areas, the countries where you aren't able to actually access pain relief. 92% almost of all opioids are consumed by high-income countries. And palliative care development is getting better, but is still growing rather slowly. We have 6 levels of palliative care development. The first is there is no palliative care, and we can't find anybody who's even interested in starting palliative care programs. The second level is there are people interested, but they haven't started actually delivering services. The third level is either isolated or generalized provision. The fourth level is preliminary integration and advanced integration of palliative care. And only about 15% of countries have good integration of palliative care. Most countries still have limited, about 2/3 of countries have limited access to palliative care. Though it has improved over time, we have fewer countries with no palliative care, and more countries becoming integrated into the healthcare system. In terms of advocacy globally, we don't just deal with these 17 sustainable goals with number 3, which is good health and well-being, which also includes in it universal health coverage. We need palliative care in order to achieve universal health coverage. The actual defined range of healthcare services goes from promotion to prevention to treatment to rehabilitation and to palliative care. So without that full continuum, you can't actually achieve universal health coverage. But we also help reduce poverty by reducing unnecessary treatments that are costing people their livelihoods and their homes sometimes. We also provide, because most people who are caregivers are women, we help support the delivery of care and the family support for care, so that we touch gender equity, we touch social inequities, reducing inequities, and it's not just about healthcare. Oops, sorry. So these are the countries where it's the darker colors are 80+% of people having universal access to healthcare. So you've already seen, and I hope you all will promote the Declaration on Palliative Care and Supportive Care to relieve serious health-related suffering for women with gynecologic cancers. This declaration, we also have now, this includes the right to palliative care for women with all gynecologic cancers, the right to palliative and supportive care, integration of palliative care, education, research, as we've been talking about, patient-centered care, and global collaboration between organizations. We're going to have a panel very shortly to talk about some of the barriers and some of the successes that we've seen in palliative care development globally. And Dr. Kichi will give us a call to action. But before I close, I wanted to just speak about an organization that we partner with the American Eurasia Cancer Alliance and have worked closely with IGCS together to help develop palliative care for all these associations. But I want to give special thanks to my colleague and friend, Dr. Sophia Michelson. The picture on the left is of us in Almaty a few months ago, in I think April of this year. And she's looking quite healthy there. But in the interim, Sophia has developed cancer and is receiving treatment for ovarian serous carcinoma. This came upon her with no symptoms. She was getting her annual physical, and her physician felt something that didn't look quite right. So had her tested and discovered that she was at stage 3B of ovarian cancer. So this is her message to us to close on. Please ensure that palliative and supportive care are integrated into GYN cancer treatment from the beginning to the end. And on that note, I will thank you very much for your kind attention. I'll say, okay.
Well, thank you, Dr. Connor, for your wonderful talk, the keynote speak. So now it's time for our panel discussions, and which Dr. Connor will moderate. But before that, let me introduce our panelists here. So the Dr. Michael Paul from the United States of America is the vice chair of the IGCS Education Committee. Thank you. And Dr. Raimundo Correa from the Chile is the current chair of the IGCS Palliative Care Work Group. Thank you.
Thank you.
And they are both GYN oncologists, and together they co-directed the development of the first IGCS Global Palliative Care in Gynecologic Oncology curriculum. Thank you so much. And Noriko Fujiwara, the same family name, but not related to me, unfortunately. She is an important part of her team as an oncology nurse specialist and a research nurse in a department that offers palliative care and modern therapeutics in Tokyo, Japan. And well, thank you for coming, and I will let you know that she had just obtained her PhD a couple of months ago. Congratulations. And Dr. Anisa Mburu from Kenya. She's a fellow of the IGCS who completed her gynecologic oncology training last year. And she is a champion for women's health and an advocate for compassionate care in her region and beyond. Well, thank you for joining us. Thank you. All right. So it's all of
Okay,
you. Please moderate.
great. Well, so we have about 20 minutes left, I guess, which is great, to try to address some key questions about integration of palliative care into gynecologic cancer practice. So we want to have a conversation about some of the ways in which we can better integrate palliative care earlier into GYN treatment. I understand. I mean, I realize it's a difficult conversation to have with your patients, but and communication skill is helpful in doing a better job of communicating with your patients. But let's talk about how do we do this? How do we integrate palliative care earlier? Who'd like to start? Wait.
Hello, good morning. First of all, I would like to thank Kishi for inviting me to be part of this panel, to Mary, to all the IGCS staff, and thank you very much, Dr. Connor, for this great lecture. And thanks for all my co-panelists today. I think we should first think that we are not looking after a single-site disease. We are looking after a human being. And as a human being, my patient has a lot of needs, had a lot of issues that as a gynecologist, I cannot look after all of them. We need a multidisciplinary approach. And when we speak about early integration, I think this is key in the sense that we don't want the oncological teams to refer patients to palliative care. We ask you, we call you to integrate palliative care as part of the oncological treatment team. And I think that's the key. We are not referring the care from one patient to the other one. That's from a clinical point of view. We are asking you to consider palliative care since the beginning. When is the beginning? Well, as stated, 8 weeks since the diagnosis. We do have, yesterday we did discuss about different screening tools that we have. We don't have a definitive screening tool, but I think the take-home care message is to integrate, not to refer. Thank you very much.
Yeah, I think that's a great point. Thank you, Raimundo. Well, and again, I think it's important to understand that we've been thinking about palliative and supportive care as about how much prognosis the patient has. We have to stop thinking that way. We really, I mean, we'd all like to see cervical cancer and all GYN cancers eliminated, but in the meantime, we have a lot of suffering, and it's the degree of suffering that should determine whether someone should be more actively treated with a palliative and supportive approach, while they're still getting active curative treatment. There shouldn't be any distinction that they can't receive palliative care if they're getting curative care. That's an artifact from the United States which we find very problematic. Would anyone else like to comment on this question?
Thank you so much, Dr. Corner and IGCS for inviting me for this. I think for one of the issues we have, especially in our countries, is that when you tell a patient that they have cancer, already that's a death sentence to them. And so if you try to initiate conversations about palliative care, all they've heard is that you're going to die. And so not many patients would even want to think about it. And so it's all about our approach on how we communicate this kind of dire diagnosis and how we advertise or explain to them the roadmap to their care. Because it's so easy to focus on the mortality instead of the morbidity of it all. And that way it might help to improve acceptance of palliative care as early as possible. Thank you.
I think I'd like to follow up a little bit on something that you just mentioned from the United States about the definitions of palliative care and how that influences management. So I'm in the state of New York. I work for a state university healthcare system. the state of New York some years ago passed what seemed to be a fairly forward-thinking law, not a regulation, a law, called the New York State Palliative Care Act. And on the surface, that sounds like an absolutely wonderful step forward for palliative care in the state of New York. But the reality is it should have been called the New York State Hospice Act because it said nothing about palliative care per se. The gist of the law is that every patient in the state of New York who has a potentially life-limiting disorder is now, their healthcare providers are obligated to tell them that hospice is available. It had nothing to do with true palliative care or integration of palliative care early into the healthcare system, healthcare services. It really is end-of-life care. And that issue, the fact that the New York State Legislature failed to understand the difference between palliative care and hospice care at their level with guidance from healthcare professionals, I think clearly indicates the difficulty that we all face with trying to integrate palliative care early into healthcare. So it's a barrier, the language, the name, names matter. Call me by my name. So the integration of palliative care early into healthcare, I think, suffers from the widespread misunderstanding that palliative care means hospice care.
Right. I think, we're really, a lot of this is about psychological barriers to patients, and some of it is our own discomfort with with talking about bad news, delivering bad news, and how we frame the question is really important. I mean, if people respond saying, oh, don't refer me to palliative care, you should probably wonder why they're doing that. There may be some fears that they have that are unfounded. Keiichi, do you have anything to say about that? I mean, Noriko, sorry. You're Keiichi. Their same last name throws me off. No.
Thank you for asking. Before that, I want to say that there is an estimated, as Dr. Kona said, 57 million people need palliative care each year, and the medical advances have led to increase early detection and the treatment of cancer. So some data show that survivor and cancer patients will be increasing double and triple within a few years in many countries. So as Raimundo said, that integration is essential, vital thing, not referral, because integration or providing palliative care into the natural part of cancer journey can not be able to done by only palliative care specialists. So everyone can provide palliative care. And as he mentioned, Dr. Kona mentioned, the communication, it's sometimes difficult, we find it difficult to communicate, just directly ask, what's your symptom to patients? And if the patient could verbalize it clearly, the problem would most likely be solved. So few patients may be able to clearly verbalize their symptom they want to say. So I believe nurse can support this part and communicate, sit next to patient and talk and make dialogue, and not only symptoms, but also their daily life. That's the key, I think.
Excellent point. Thank you very much, Noriko.
So
Michael.
So let me just follow up on that a little bit. I think that as in everything else, it's about communication, communication, and communication. It is a philosophical approach. So I can, obviously I'm sitting here, I firmly believe in palliative care approach to healthcare. So when I speak with my patients, this is something that comes up very early in the conversation. I've had partners over the years where they truly emotionally can't do this. And it then becomes a burden for the patients. So I think if we put the patients first and their families along with them, and try to view how we can best help them. It isn't always about the most complex surgery or the newest chemotherapy combination or immunotherapy or ADC. It is, at its core, it is about an individual person and how best we can care for them.
Thank you, Raimundo.
Yes. Thank you again. Communication is difficult. Communication is an art. And probably we need to have some formal training to the students, to the fellows about communication. Here, I do have two glasses, a full one and an empty one. We try to convince the patient and the correspondent family and caregivers to be and to see the full one. Whatever you want to say to the patient, you need to give a hope. And I think this is crucial. All patients want to live. They know they might die at some point, and they are afraid because they feel alone. We need to take care of that, and we need to let them know that they won't be alone. And this is not easy to say when they have only a few weeks of life. It is easier to say with plenty of time. And this is also the part of the advanced care planning that each patient should have.
Minutes, but do we have 7 minutes?
We have 7 minutes.
Okay, good. Excellent. Yeah, you know, when I would go to the bedsides of patients that were referred for palliative care, I felt, you know, I took the attitude that I have a really wonderful opportunity for you to consider, and there's so many things that we can do for not just the patient but their family. And patients oftentimes are more concerned about their families um, than they are about their own condition. So when you say, like, we're going to be visiting you regularly, we're going to teach and we're going to support, we'll be there 24 hours, available by phone at least. That's so reassuring to patients. It's like a gift. Quickly, and then we'll move
Yes,
on to the.
and from that point of view, also reinforce the concept that palliative care is not only until the patient dies, also from the bereavement period.
Yeah, let's talk about some successful programs in delivering palliative care. How have we overcome some of the barriers that we've been talking about? Any examples that we can share with you?
Thank you for the question. I want to talk about this point from an LMIC because obviously I'm from Kenya, Africa. And one of the key things that I see that has helped palliative care move forward in our country is by establishing a palliative care society. And this society has been able to work together with the government, with the Ministry of Health, to push forward the agenda on the mandate of palliative care services and hospice care. Through our palliative care society, we've been able to establish about 102 palliative care units in our country. Still few, but we've started somewhere. And with this kind of centers, there's always an element of the training that keeps going on. And that's the next thing that we've had in terms of success. In Kenya, I'm proud to say that in terms of education, every medical school and nursing school, any curriculum that deals with medical health, has 100% incorporated palliative care in the curriculum. This way, anyone who's graduating from any medical course, they are able to at least have a basic knowledge of palliative care. And this, as much as implementation is still a struggle for us, but when they have that basic knowledge, at least we're not starting from zero. And at the same time, while we're still trying to build our own palliative care specialist, as it stands, we have only 5 main medical specialists who have qualified, but we have other cadres who are still learning. We still have a lot of inter-country collaboration where we have partnerships with hospitals in high-income countries that have established palliative care services and even medicines and technologies. And through this kind of partnerships, we have this specialist coming to our country and us going to their country as well. And that way, that kind of collaboration has really helped achieve success in helping palliative care. And the last thing I will mention is incorporating palliative care in the National Hospital Insurance Fund cover, which we should call NHIF. This hospital insurance fund, at least it's healthcare insurance for most people that have apply for it. And for our patients, it is able to cover for them some of the essential medicines like opioids. And also, if a patient is at the end of life and they need hospice care, they can be admitted in a hospice center, and the National Hospital Insurance Fund can cover at least the bed cost and some of the basic costs. And this has really helped in promoting the palliative care agenda in our country. Thank you.
Kenya has really been a leader in terms of universal health coverage and inclusion of palliative care. It's a great example of that for other countries. Other ideas for programs?
Yes, the Japanese palliative care progressed under the national policies supported by the Cancer Control Act 2007. So continued education for physicians, doctors, and other healthcare professionals is performed after, and around 0.2 million physicians have been educated in this nationwide two-day program so far. And IDCS have great palliative care curriculum. So thankfully, we can learn, not only doctors, but also everyone can learn from that curriculum. That is the key.
So on the map, the United States is dark blue, leaving the politics aside, I guess, but it's dark blue, indicating that we have an advanced palliative care integration program. While that is probably true on a national level, it's not true on entirely equitably across the country. So I think that the approaches to developing a successful palliative care program has to do with the tenets that Dr. Connor discussed. We need research, we need early training. It doesn't help to teach old dogs new tricks as much as teaching the puppies. So I checked with our institution, for example, right before I left. Just in the last few years, our medical school curriculum includes palliative care. But prior to 5 years ago, there was no palliative care training for the medical students. The residents under the graduate medical education program are now offered the opportunity to take palliative care training, but it is not obligatory. Within the gynecologic oncology training, I checked with the American Board educational bulletin, and there is a section on palliative care, but it's buried very deeply within the bulletin, and majority of it is focused on surgery, radiation, chemotherapy, the standard tenets of gynecologic oncology practice. So I think that the success depends upon early integration of palliative care education, since we're going to talk about integration, palliative care integration into healthcare training. It involves communicating very carefully and thoroughly with the patients, and then working very carefully with the governmental agencies that oversee healthcare within whichever region.
You have a final comment, Raimundo?
In Chile, since 2006, we do have some sort of a new health system with some protected disease, where the government secures patients to have the treatment done for this specific disease. Palliative care was one of the first diseases to be protected. Unfortunately, it is only for oncological patients, not for non-oncological cancers, non-oncological diseases, sorry. But we have something. There is a law accepted and approved 2 years ago, but there are still some administrative issues.
Hmm.
And the last thing in terms of education, we just, not at my center, in another center, they just started a formal training program. So many of the palliative care physicians in Chile, some of them did a self-training, and the other ones, we had a formal training out of the country.
Great. Okay, well, I think in the interest of time, I want to thank the panelists for your good counsel and advice to how to overcome some of these barriers. We were going to talk about how to use the new declaration to advance access to palliative care, but we're going to have a example of that right now from Dr. Keiichi. Thank you all very much.
Thank you. Thank you so much for the great discussion here. So I think it's I will end this session with a call to action. So okay. Oh, so because of the time is limited, so I really want to read maybe later on. So we have 1, 2, 3, 4, 5, 6 actions. So this will be on the web page, and we put the order from the things that we can do tomorrow. Okay. So please take your time to read this. Very important things. So once again, well, thank you. Very nice panel discussion. And to close this session, I'd like to give you a token for appreciation from the IGCS. Okay. Dr. Connor?
Thank you very much. It's very kind. And it's a good thing we took the pictures beforehand, so we don't have to worry about that. Thank you.